Can you all hear me?
Good afternoon, sir. We can hear you.
Okay. Now we are going to start our lecture on the diseases of the nose and sinuses. And first, I would like to give you a classification of the conditions that we are going to discuss. Little bit of yes. Congenital conditions are there in the nose and sinuses, which are choanal atresia, dermoid cysts, various sinus tracts are there. Meningocele and enteroperocele also can be congenitally present. Then the traumatic conditions we are going to discuss: soft tissue, bone and cartilage, which can involve the frontal bone, nose, ethmoid sinuses, maxilla. Then the blowout fracture. Then the zygoma, lateral malar zygomatic fracture. And also middle third fractures, which are called LeFou fractures. Then the infective conditions in yellow, vestibulitis. The nasal vestibule is the lowermost part of the nose. Vestibulitis, rhinitis, sinusitis, which can be viral, bacterial, or fungal. And then allergic rhinitis. Then we have the neoplastic conditions affecting the nose and sinuses, the benign neoplasms like ethmoidal polyps, antrochoanal polyps, angiofibroma. Then there is intermediate category polyp called inverted papilloma. And then the malignant polyps, malignant masses in the nose, out of which the common few I have mentioned here: squamous carcinoma, adenocarcinoma, and adenoid cystic. But there are other types of carcinoma also rarely and occur. Then there are autoimmune conditions like sarcoid and vaginals also can affect the nose. Then the miscellaneous conditions, epistaxis, offensive smell from the nose. Then we discuss about imaging, and then also there's a condition called rhinoscleroma, rhinophyma. Then at the end of the session, we will talk about some of the operations that we commonly do: septoplasty, nasal polypectomy, lateral rhinotomy, medial maxillectomy, total maxillectomy, and functional endoscopic sinus surgery. So this is the general format of our two lectures. And this is basically a classification of conditions that we want to discuss. Now, choanal atresia is the condition that we want to talk now in with more detail. We try to define the choanal atresia. It is defined as non-canalization of the posterior choana. Now, as you know, the nasal cavity opens into the posterior nasal space by an opening called choana, C-H-O-A-N-A, and this opening, if it is not there when the baby is born, then we call it choanal atresia. Choanal atresia can occur on one side, which is unilateral, and if it happens on both sides, it's bilateral. Unilateral choanal atresia can be relatively less harmful because the other side will allow the air to pass through. So sometimes it is asymptomatic and it may not be diagnosed at birth. It may be diagnosed sometime later. Bilateral is a urgent situation because if you get bilateral choanal atresia, your nasal passage is completely closed in the back of it, and there won't be any nasal breathing. As a result of that, when the baby sucks the breast or when the baby closes the mouth, the oxygen supply is completely stopped. So cyanosis can occur, feeding problems can occur as a result, of bilateral choanal atresia. So it can be an emergency at birth. So baby will become respiratory distressed every time the baby is fed or when the baby's mouth is closed. That can lead to intermittent cyanosis. In this diagram, you can see how one side of the posterior nasal space is not canalized, whereas the other side is open to the nasopharynx. So this is the nasal cavity, nasal septum, and opening into the nasopharynx is here, but this side it is not there. So it is unilateral choanal atresia. Now the atresia can be sometimes by a membrane, or it can be like a bone. So membranous atresia or bony atresia can occur. Normally there is a good amount of misting due to the nasal airflow, but if there is no misting, then it is bilateral choanal atresia. Also, you can pass an NG tube into the nose and see whether it can be seen in the mouth. On both sides, you can try this. Then, if you instill a radio opaque dye and take an X-ray, that might show the dye is collected in the nasal space. And also the non-contrast CT scan is the other way that we can find out about this condition. So CT in addition will help us to see whether the atresia is a membranous or a bony atresia. There's a problem of moving the slide. Right, okay. So treatment is urgently necessary for bilateral choanal atresia. Examination under anesthesia and perforation of the membranous or bony atretic plate. And then once you perforate, we have to keep it open because it can get closed sometimes. So you have to keep what is called stent to keep the lumen open. But sometimes you can get a restenosis because the stent we can't keep permanently. The stent we usually take after a few weeks, and then if it again closes, then you may have to treat again. Then the congenital sinus tracts and the dermoids. Now, when these sinus tracts, these are not paranasal sinuses, these are sinus tracts. So, sinus tracts can be there in midline because midline is a fusion area in the embryo. So, in the midline, when the fusion doesn't take place, or midline structures don't fuse with a continuity, you can have a small tract passing deep. So what can happen is these tracts can be communicating with inside your nose and sinuses, or it can have a blind tract. But because it has a lining, sometimes it tends to have certain amount of discharge, or some debris can collect inside, and this can get infected. So that is the importance of these sinuses. So in this patient, you can see there is a small sinus, the root of the nose area. Then this one has a sinus here. And so these are the sinuses. So if these sinuses are troublesome or if they are cosmetically, anyway, they are in front of your nose, it is probably not very nice cosmetically. Therefore, it's better to treat, and the treatment is usually completely excising this sinus tract, and then you can repair the skin. So congenital sinus tracts you might see in the newborn or in children, and they can come with sometimes symptoms of infection or abscess formation. And if it is acutely infected or inflamed, that is not the acute infection. Talking about the trauma of the nose and sinuses, trauma to the nose and sinuses can have cosmetic aspect, where the deformity can cause ugly appearance of the face. The types of injury can be soft tissue injuries like lacerations and contusions. Then bone and cartilage injuries can be there, which can be fractures, and also fractures can be simple or compound fractures. The diagnosis of traumatic injuries is by taking the history and then examining the patient. By inspection and even palpation of the facial contours will tell us whether there is a discontinuity or whether there is significant tenderness, because if there is a fracture, we will have significant tenderness of the fracture line. And by examining, by inspection and palpation, you can have some idea about the areas that are damaged or fractured. Imaging is necessary to exclude bone injury. The treatment is usually by thorough cleaning. They have to do a meticulous repair of the soft tissues. Subcutaneous layer is important in the facial areas because there are muscles attached to the skin. So if you don't have a good subcutaneous suturing, the scar can be prominent. So skin is usually closed with 5-0-proline. That is a very fine suture. 5-0-proline is a very fine suture, which is used to close the skin on the nose and the face. And sutures are usually left for 5 days. And coming to individual bones, now frontal bone, as you know, is the frontal area or the forehead. Injury can cause frontal bone fracture. Frontal bone houses the frontal sinus, and the frontal sinus has an anterior wall and a posterior wall or anterior table. If you get an injury to the frontal bone and your frontal anterior table fractures into the sinus, then there is going to be a cosmetic deformity or a depression of the frontal bone, which can be cosmetically bad appearance. But if you fracture the posterior table of the frontal sinus, then it can be further serious injury because dura is behind that. The dural damage can lead to CSF leak through the nose, and that can lead to meningitis and complications. So, frontal bone fracture, whether it is anterior table, posterior table, or both tables, we like to know. Imaging usually helps us to see whether the two tables are fractured or one table fractured. X-rays and CT. CT is more helpful. X-rays may not show very clearly the fracture lines. So nowadays, most of the time, CT is used. And the treatment is the anterior table fractures. We can elevate by external approach and then fix the bone to the surrounding, either by plates and screws we can use, or even by sutures you can fix the bone to the surrounding bone. So anterior table can be done without much problem. Posterior table with brain involvement, then of course there is a problem of covering repair, so we might have to do it with the neurosurgical team or If you want to do a repair, sometimes you might have to do open repair because if there's a dural damage, then you may need to do the repair of the dura also. When you get fracture of the nasoethmoid complex, there can be different degrees of severity of the injury, and according to this severity, they are classified. The class 1 nasoethmoid complex fracture is a depressed or deformed distal nasal bone. So, distal part of the nose is depressed in the class 1 fracture. Class 2 fracture is defined as lateral deviation of the bony nose. Now, bony nose is actually the upper part of the nose. It is here. So, this upper part is deviated to a side, then we call it the lateral deviation. And class 3 is the ethmoid fracture, which is like nasal bones have gone into the ethmoid sinus. The imaging by X-ray and CT. The treatment is manipulation under anesthesia and fixation of the fractures. Because class 3 fracture can sometimes give an ugly deformity like pig face. And also when you are trying to elevate this kind of fracture, you have to be aware that even the cribriform plate area might have a fracture. So when you are using the instruments to elevate these fractures, there can be a possibility of CSF leak. So that we have to be aware of that possibility. So this is a class 2 fracture with a deformity. Epistaxis, deformity, deviated nasal septum can occur. And also septal hematoma is a condition that can occur after a nasal injury. So septal hematoma is considered an urgent situation or emergency. Because after nasal injury or after minor nasal injury, sometimes you find that the patient develops severe nasal obstruction bilaterally. In the next few days, they can come with this problem. So if you have this kind of bilateral septal swelling after minor injury, then it is likely that the patient has got a septal hematoma. Septal hematoma occurs under the septal mucoperichondrium, and when the mucoperichondrium is separated from the cartilage might not be able to get the nourishment. So you can get cartilage necrosis, and cartilage necrosis can give rise to a saddle nose. So because of that nasal septal hematoma, they had to quickly diagnose, admit, and drain urgently because that is the way to preserve the cartilage. So when you have a nasal fracture with deformity, how long we can wait? Now correction usually we recommend within about 3 weeks of injury. Immediate correction sometimes may not be good because of the swelling that can occur after injury. So if there's a lot of swelling, you might not be able to see the alignment of the nasal pyramid. Therefore, it is always good to give an antibiotic to the patient and then review after 1 week. And once the edema has settled, then we can plan manipulation next week. So we do a manipulation under anesthesia. We put nasal packs to help the bone fragments to remain in place. Also, sometimes we put an external small piece of plaster of Paris over the nose to try and hit the alignment. If immediate or within a reasonable time, if we have not managed the nasal fracture, the bone will become hard after some time, and then we will not be able to mobilize the bone. So later on, if you want to do anything, it is a rhinoplasty or septorhinoplasty to correct the shape of the nose and the septum. So therefore, nasal fracture with a deformity, it is best if you can do a early correction within 3 weeks, which is like a closed manipulation, and that's a simple procedure. But if it doesn't happen or if it is not done, then later on it's a more complex procedure, more time consuming procedure, which is called rhinoplasty or septorhinoplasty. So the lateral part of the face, which is the malar zygomatic complex, can get fractured due to a blow on the lateral face, and sometimes this segment can get depressed. So if it goes into the soft tissues, then the patient might develop certain physical signs. One is the flattening of the cheek lateral aspect, flattening, and also they might have trismus. Trismus is difficulty in opening the mouth. So we may have to use some technique to elevate this fracture. Colwell lock operation is one of the older operations that we used to do by retracting the upper lip. You can see that we have made a hole into the sinus, maxillary sinus, and through the maxillary sinus you can push the bone laterally to this malar zygomatic bone here, and then pack the area. Also external exploration and plating can be done. Also sublabial exploration without going into the sinus can be done. Now next thing is the blowout fracture, which is a fairly classical condition that we see. It is an orbital flow fracture. If you get a blunt injury with a blunt object to the eye like that, then the globe will be compressed against the bony cavity, and due to the force, the orbital flow can get fractured, and then part of the orbital contents will prolapse into the maxillary sinus. Now this is what you see in this scan. The orbital contents have gone into the maxillary sinus with a discontinuity of bone. You can compare with the normal side. So this will cause certain amount of depression or inophthalmos, we call it. Inophthalmos can occur as a result of blowout fracture. Then also similar injury can occur to the inferior orbital rim fracture if you get a blow on the face or the cheek. There you can feel a tender deformity in the inferior orbital rim. If you run your finger along the inferior orbital rim, you might feel a step deformity, and tenderness also might be there. So if you want to document or see further, we can do X-ray or CT. And these two conditions, the orbital flow fracture and the inferior orbital rim fracture, can sometimes affect the visual function or the vision, because among these fracture fragments you can get the inferior rectus muscle trapped. So if the inferior rectus muscle gets trapped in the fracture, then the patient can develop diplopia. If that doesn't happen, they may not have diplopia, but they can have sometimes inophthalmos, but no other problem. So if there is a visual effects or visual problems after inferior orbital rim fracture, we generally get the ophthalmology colleagues to repair that, because they are the people who are aware of these muscles and how to release and how to reconstruct they will do the repair. Then we come to the LEFO fractures, which are of three types, the middle third phase fractures. Important thing about LEFO fractures is that they can cause upper airway obstruction. So if you get a facial fractures like this, then you might have upper airway obstruction and that can kill the patient. So therefore, if a patient comes with a multiple facial fractures, there is a definite risk to the airway, and we should establish the airway or safeguard the airway, because that is the thing that can kill the patient. So you can we describe in the books three types of LEFO fractures. The upper alveolar fracture is LEFO 1, that is this line. Then there is a bit of a pyramidal shape fracture involving the nasal bones and the maxilla, which is called LEFO 2. Then there is another fracture which is going like a W. Is the most severe type or LEFO 3. So again, these fractures are usually treated by our facial-maxillary colleagues, and we need to give antibiotics initially and establish the airway or safeguard the airway, and the patient can be subsequently referred to the oromaxillofacial team for definitive repair. Usually, they will do plating. Plates and screws are available. Mini plates can be used, and then mini plates and full screws, if you use in the right correct places, then you can reduce the fractures and fix the fractures. And this is the picture of lateral fracture of the face, which we earlier talked about. You can get a fracture here, you can get one here, get here, and this segment can get forced into the tissues. Then we talk about the infective conditions of the nose. The anterior part of the nose or the lower part of the nose can get infected because it's a hair-bearing area and it contains organisms also. Staphylococcus can be there in this hair-bearing part. So sometimes you can get a hair follicle infection by Staphylococcus, which is called Paranasal, and sometimes it can lead to abscess formation. So vestibulitis can occur just a infection of the soft tissue, or it can form abscess. So you get a swollen, red, tender vestibule. Sometimes it might form abscess and discharging point may be seen. Diagnosis is usually clinical. Antibiotics, oral or IV, can be given depending on the severity of the patient's condition. If there is an abscess, we can do incision and drainage. Topical antibiotics can be applied like fusidine or some anti-staphylococcus cream, but most of the time systemic antibiotics are necessary to resolve the condition. Now, these infections can have a risk of infection spreading into the cavernous sinus. So that is important to realize. Therefore, they should be promptly treated to prevent a nasty condition called cavernous sinus infection. When we come to the conditions of infective conditions of the nose, rhinitis. Rhinitis, it indicates that there is an infection in the nose. You can get acute rhinitis or chronic rhinitis. It can be viral, bacterial, or even fungal. Typically, burning sensation can occur in the nose, obstruction, and excessive discharge causing rhinorrhea. Most of the viral rhinitis tend to resolve by itself after a few days, so we don't really need to treat these conditions. But some of them can lead to sinusitis, or the sinuses can get involved with the infection. So acute rhinosinusitis is acute inflammation of the mucosa of the paranasal sinuses with or without obstruction to the drainage. So when you get acute sinusitis, you get the sinus mucosa inflamed, infected, and excessive secretions. It might collect the secretions inside the sinuses, and the sinus ostium can sometimes get blocked. And if this happens, then the patient can develop significant trouble or symptoms. And depending on the sinuses involved, the symptoms are referred to the area of the sinus. So we get commonly frontal and maxillary sinuses getting sinusitis because they are the anteriorly placed sinuses. Then the ethmoid sinuses are generally a little deeper. They are between the eye and the nasal cavity. Sphenoid sinus is the deepest sinus, so that doesn't get frequently infected because it is not exposed to the external air or the dust or whatever we breathe. Therefore, sphenoid sinus doesn't get that frequent infection. When sinusitis occurs, the edema of the mucosa can obstruct the sinus ostium. So then the sinus gets filled with pus, and that can give rise to significant pain and tenderness. So what do they come with? Normally they will have headache, they can have fever, nasal obstruction, facial pressure, excessive nasal discharge or rhinorrhea. Now postnasal drip is that the discharge can track down into the nasopharynx and from nasopharynx to the oropharynx. So that can be a feature of sinusitis, acute or chronic, where the patient says that all the time I can feel some mucus or some phlegm or some bad taste is stuff is dripping down to my throat. So that is postnasal drip. And also pain in the eye may be a feature of ethmoidal sinus involvement. Now when you examine, how are you going to find whether it is sinusitis? Externally, we can check for tenderness over some of the sinuses. In the frontal sinus floor, which is here, if you press on the frontal sinus floor, patient is tender over that area, then we can suspect frontal sinusitis. Tenderness over the maxillary sinus, we can check by pressing on the anterior wall of the cheek. The anterior wall of the cheek pressure will give some pain in the case of maxillary sinusitis. Ethmoidal sinusitis cannot be pressed because they are deeper. Sphenoid sinus also cannot be checked like that. So only frontal and maxillary we can check for tenderness. Diagnosis is mainly clinical. Nowadays, most of the places they have rigid nasal endoscope. So our standard examination using the tudicum speculum sometimes doesn't give us adequate view into the nose. So nowadays, people say to diagnose acute sinusitis, you have to do a rigid nasal endoscope. So if you have rigid nasal endoscope, then you can spray some local anesthetic into the nose and carefully pass the endoscope. And if you have a monitor to display the picture, so much the better. So you can pass it and you look at the monitor and whatever the problems or abnormalities in the nasal cavity you can demonstrate, and then that will help you to diagnose sinusitis. So inflamed mucosa, pus tracking down from the middle meatus, those things might indicate that there is acute sinusitis. The imaging sinus X-ray occipitomental view is not helpful in the acute phase. So there is no point in doing X-rays for acute sinusitis. Acute sinusitis is diagnosed clinically and we treat on the clinical diagnosis. So no point in doing CT scans, X-rays for acute sinusitis. it is better to make clinical diagnosis and treat. So what is the treatment for acute sinusitis? You can give antibiotics oral or IV depending on the patient's severity of infection. Most of the normal people without comorbidities can take oral antibiotics and they may get better. But if the patient's condition is not good and it has multiple comorbidities or if there's immunosuppressed situations, then we might admit the patient to give intravenous antibiotics and at the same time we can manage their comorbidities as well. So 1 to 3 weeks antibiotics, antihistamines also we give. Sometimes that might help to reduce the irritation of the nose. Nasal decongestants are nasal drops that we use for these patients. So there are nasal decongestants which are fairly powerful, but they can be used only short term. So these preparations contain oxymetazoline and xylometazoline and ephedrine. These are the preparations which are used for short-term treatment. So oxymetazoline, xylometazoline, and ephedrine. So when you see the nasal drops, you can look at the box and see what is the active ingredient. If it is oxymetazoline hydrochloride, or it is xylometazoline hydrochloride, or it is ephedrine hydrochloride, then these are the short-term nasal drops. They should not be used on long term because they can have more trouble if you use it for a long time. Steam inhalations are very beneficial for nose and sinuses or sinus health, especially when there is infection and when there is obstruction to the sinuses. So steam inhalations will help us to make the cilia movement better. Ciliary movement, the nasal cavity has a mucociliary mechanism to transport mucus. So steam inhalations will enhance the ciliary activity, and also the steam is a mucolytic substance. So thick mucus can be made thin by inhaling steam. So traditionally also we have been advised by our village physicians sometimes to take steam inhalations. So this is very useful even in Western medicine. I think it is useful. Nowadays people recommend a lot of steam inhalations because of the COVID infection, and they believe that COVID virus can be killed by the steam, but I don't know how far scientifically that is proven. So a lot of people now recommend steam inhalations, even without any illness. Some people take steam inhalations. So analgesics also helpful if there is pain. Now, when you get acute sinusitis, in adults usually there is no external swelling, but in children we find that the area gets swollen. So swelling over the sinus is common in children, but not in adults. If there is poor response to treatment, then we have to see why. Sometimes patient may be having undiagnosed condition like diabetes, or there may be sinus collecting a lot of fluid or pus unable to drain due to the obstruction of the ostium. So then we might have to do imaging. So X-ray sinuses OM again is not very useful nowadays because we have the CT scans. The CT sinuses are very useful if you want to visualize the sinuses. But again, you must realize that in the acute phase, if you do CT scan, you will see a lot of edema, a lot of fluid, and a lot of shadows. So it is probably not a good idea to do the CT scan in the first instance. But if the patient is not responding well, or if there are any signs of complications developing, CT scan has an important place. So we don't do CT straight away on the first visit, but we treat them, and if they get better, there is no need of CT. But if they come back again and complain the same thing, or if they come back again with any signs of complication developing, then the CT scan is very useful. So we usually do non-contrast CT scans for this type of patients, NCCT we call it. Now, what are the reasons for poor response of the treatment of sinusitis? Now, if the nasal cavity is obstructed by a deviated nasal septum, which is called DNS in short, and also if you have polyps in the nose, those polyps might be obstructing the nose, and sometimes the sinus is filled with pus. As you know, the mucociliary transport mechanism in the sinuses takes place only when the sinus is aerated properly. But if the sinus is filled with water or fluid, it may not happen. So therefore, sinus filled with pus may not clear easily. So they will come back to you. Then of course, as we said, the immunosuppressed state like diabetes or your kidney transplant, you can get patients with poor response. If the patient doesn't improve sufficiently and the symptoms persist, then we can do X-ray sinuses. And if the X-ray shows fluid level in the sinuses, maxillary sinus can be seen. Sometimes it has a fluid level. So if there's a fluid level, there's a horizontal level with opacity below. Traditionally, or in the olden days, we used to do sinus washout or antral washout, we call it. This can be done under local anesthesia, and there the doctor will have to do it after explaining to the patient. We pack the nostril with some local anesthetic, and then we have got a trocar and cannula, which is a device to pierce the sinus. And once you pierce into the sinus through the medial wall, the cannula is kept in place and the trocar is taken out. So we have a passage leading to the sinus. Then you can take some specimens from that sinus, and then you can wash the sinus. So antral washout is washing out of the maxillary sinus, and that sometimes helps the other sinuses also. By washing that area with saline, we might unblock the other sinuses, and that sometimes helps the frontal and the ethmoid sinuses also. So although we do only maxillary sinus washout, we have found that patients get a benefit for the ethmoid sinuses and frontal sinuses also. Now, recurrent or chronic sinusitis can occur as a result of incomplete treatment or predisposing local causes or predisposing general conditions like immunosuppressed state. So some people come with repeated episodes of these things. Some people after treatment they get better and they may not come back to us. So therefore, these patients should be evaluated carefully so that we know that they are either they have taken the treatment properly or whether we have not controlled their diabetes or any other condition. So patients has to be evaluated properly. The treatment is with antibiotics for chronic sinusitis also you can give, and sometimes you need to do surgical exploration of the sinuses when they have recurrent or chronic sinusitis. So these are the surgical procedures that had been described. Intranasal antrostomy. Intranasal antrostomy means we make an artificial opening into the maxillary sinus through the nasal cavity via the inferior meatus. So the normal maxillary sinus opens in the middle meatus, but in this intranasal antrostomy, we make an opening artificially into the inferior meatus, which used to be a common procedure earlier, but nowadays people don't do this very much because people have found that the mucociliary flow in the maxillary sinus is towards the natural ostium, which is in the middle meatus. And if you make an artificial opening in the inferior meatus, that is inferior to the inferior turbinate, that mucus clearance does not occur into that. They have demonstrated. So intranasal antrostomy is not commonly performed now. Septoplasty, most of you would have seen this operation. If there's a septal deviation, we try to correct that from inside the nose. There are nasal polyps, of course we have to clear the nasal polyps, and that might help you to drain the sinuses. Then turbinate diathermy and trimming. The inferior turbinates can be very large sometimes, causing obstruction. So they might need submucosal diathermy or trimming. An ethmoidectomy might be necessary for some patients if the ethmoids are affected and they are not resolved. Then what we call FES is functional endoscopic sinus surgery. So this is what we do in endoscopic sinus surgery. A rigid telescope is inserted into the nose, and various areas of the nose can be seen very clearly on a magnified view on the screen. So if you connect the endoscope to a camera, and this is only endoscope here, if you connect it to the camera and transfer the image to the monitor, the surgeon can watch while inserting it into the nose. Surgeon can watch on the monitor what is happening and where the endoscope is. Now we come to complications of sinusitis. Now complications of sinusitis are important to know because sometimes the patient might present with a complication and sinusitis may have gone unnoticed. Patient comes with a complication. So one of the very important complications is orbital cellulitis. Now, orbital cellulitis is a problem when sometimes the ethmoids get infected. The ethmoids are bordering the orbit. So if you get ethmoidal infection, sometimes the infection can go into the orbit. So how would you recognize in the early stage? A swelling of eyelids is one of the conditions early that will manifest, uh, indicating that they are going to be orbital cellulitis. So it is swelling of the eyelids that should alert a person that this patient is getting orbital complications. And if you get full-blown orbital cellulitis, you might lose vision completely. So therefore, you must prevent it happening at all costs. And if you see a patient with swelling of the eyelids, and if they have features of sinusitis also, it is best to admit this patient uh, because we need to give IV antibiotics promptly and then see whether the infection spreading out of the sinuses can be aborted, and especially to prevent it going into the eye. So if there are eyelid swellings in a patient who is suspected to have sinusitis, then that indicates that the infection is going out of the sinuses. So that is an important thing to remember because we can have orbital cellulitis, we can have orbital subperiosteal abscess. So certain things that can occur affecting the orbit, and if you are aware of this, you will recognize it in early stage, and early stage recognition will help us to aggressively treat these patients, and aggressive treatment might prevent vision loss. So that is important to know. Then you can get meningitis, the infection spreading into the brain, which can be diagnosed by the patient becoming feverish, severe headache, vomiting, and also the signs of meningitis like neck stiffness and Kernig sign may be there. Sometimes patient might get a condition of cerebral abscess. The common area that you get cerebral abscesses after sinusitis is the frontal lobe. So you can get frontal lobe abscesses secondary to sinusitis. Now this is how orbital cellulitis could appear. So small child, you can see grossly swollen eye, completely closed, redness and all that. So that is picture of orbital cellulitis. Then other complications of sinusitis, you can get osteomyelitis of the frontal bone after frontal sinus infection. Now this is This is a picture of what is called Pott's puffy tumor. People earlier used to think that this is a tumor, but later on they realized that it is a osteomyelitis of the frontal lobe. Then, of course, the cavernous sinus thrombophlebitis is another important complication of sinusitis, because cavernous sinus can get infection from the facial veins, and it can go into the pterygoid plexus, and the pterygoid plexus can communicate, or it is communicating directly with the cavernous sinus, so the infection can end up in the cavernous sinus. So cavernous sinus thrombophlebitis is one of the conditions, and then you can get otitis media or middle ear infections, and also you can get pharyngitis as a complication of sinusitis. Now, this is a picture of cavernous sinus thrombophlebitis. You can see that a lot of edema of the eye and proptosis is there. Proptosis, chemosis, conjunctival chemosis, and ophthalmoplegia, and fever. So nowadays we don't see this condition commonly, but the day you see, you must immediately recognize the problem, because it can have serious consequences. Therefore, we must quickly admit the patient and treat promptly to control the infection. Then we come to the neoplastic conditions, which out of which we start with the benign conditions. Benign nasal polyposis is a common disease. Some people develop multiple polyps in the nasal cavity, both sides. So these multiple polyps, or these polyps, occur in the ethmoidal mucosa, and they come down into the nasal cavity through the middle meatus, and also posterior ethmoids, which are actually above the level of the middle meatus attachment. You might get these polyps coming behind the middle turbinate. So multiple recurrent polyps can occur. The etiology of benign nasal polyps is not known, and some people suspect whether there is allergy. Some people think whether it is a fungal etiology, but no one knows exactly how or why people get benign nasal polyps, which are arising from the ethmoidal sinus mucosa. But they are considered, they are not considered as true neoplasms. They are more like hypertrophy of the mucosa of the ethmoidal labyrinth. So what are the clinical features of these patients? They usually get nasal obstruction, progressively worse, and then they get nasal discharge, which is called rhinorrhea. The nasal bleeding is uncommon in this condition. And if you get this patient with these complaints, when you examine the nose with anterior rhinoscopy, you might see the polyps, which are like bunch of grapes, and get like multiple grape-like polyps in the nasal cavity. So that is the typical appearance of benign ethmoidal polyps. Now in this diagram, in this picture, you will find that this gray colored one is the polyp. This one. This one is the inferior turbinate. And this is inferior turbinate. This one is inferior turbinate, and behind the gray color, like it looks like a little grayish mass, and that is the polyp. So you can differentiate by looking at the color, and also these polyps usually start high up here in the middle meatus. So if you focus this up, sometimes you can see they are coming from the middle meatus. Whereas this one, which is like a large rounded lump, is a turbinate, which is commonly inferior turbinate. So benign nasal polyps can be diagnosed by examination with the tunicum speculum, and we usually don't do a lot of imaging for this condition initially because we can diagnose them clinically, and the treatment is initially conservative. So we treat them conservatively. Uh, the things that we usually give them, they are given antibiotics for about a week. Then you can give oral steroids, short course, because that will have a very powerful effect to reduce the size of polyps. So they will quickly get smaller and the patient feels better very quickly. If you use oral steroid, short course, then you have to use topical steroids, which can be used on a long term because we can maintain the patient's response by using topical steroids. And the antihistamines also will help to reduce the amount of nasal discharge. So these are the ways that we manage the benign nasal polyps, conservative management. And if the patient gets a good response, then we can continue on topical steroids and antihistamines. The topical steroid sprays are available, or they are available in the form of drops. So if you're using nasal drops, again, you can use it on long term provided they are steroid drops. But sometimes the spray might be easier to use. So spray also available. Steroid nasal sprays are available. So we can use a steroid nasal spray sometimes 3 months, 6 months, or even longer than that, depending on uh, how the patient is responding to treatment. If you are using a long-term steroid spray for any nasal polyps, we generally recommend you to go to a smaller dose because we don't want to use a lot of steroids on the patient. So what we do is we initially get the patient to use the steroid more frequently, maybe 3 times a day. You can use 1 puff into each nostril, and 3 times a day to start with. Once the control is achieved, we say step down or come down on your dosage. So you can make it twice a day and even once a day and sometimes maybe every other day. So if you want to go down on your dosage, we say go to the minimum dose that you need to control your symptoms and you can use it for a long time. If the response to treatment, medical treatment is poor, then we might have to consider surgery. Now, surgery can be done by a traditional technique of using your headlight and then looking into the nose and using forceps to pull out, or we can do endoscopic sinus surgery. With the endoscope, we can see very well, and there are instruments to take the polyps out through the endoscope. So both techniques can be used. Most people nowadays use the endoscopic technique. Then the other type of polyp that we are going to talk about is called antrochoanal polyp. Antrochoanal polyp is benign condition, which is a single polyp, and it starts in the maxillary antrum and extends into the nose, and it tends to grow towards the choana. So that is antrochoanal polyp. As a result of the polyp coming out into the nose, of course, when the polyp is in the maxillary sinus, they may not have symptoms. But when it goes into the nose, they'll get unilateral nasal obstruction initially. But after some time, it becomes bilateral because when you go to the posterior choana and the nasopharynx, it is one cavity. So therefore, the polyp might initially block the side of origin, but once it goes into the nasopharynx, it might go into both sides. So bilateral obstruction can occur. And if the polyp grows further and very large, then they might even cause a lump in the throat. So when you open the mouth, you might see a lump hanging behind the soft palate. So diagnosis of this polyp is by examining the nose and demonstrating the polyp on one side, and then it might be in post-nasal space. Sinuses OM X-ray, if you take, you might see one side opaque antrum, and the CT scan will show again the antrum calcified. Treatment is surgery. Surgical removal completely is necessary because polyp originates from the maxillary sinus. Therefore, nasal polyp or nasal part can be removed easily, but the part inside the maxillary sinus can grow again if you don't remove the sinus component. So you have to do nasal polypectomy and you have to do a surgery to get the polyp out of the sinus. Now we have an operation called Colwell operation, which sometimes we use to take this polyp out from the maxillary sinus. But this operation is not good to do in children. So Colwell operation, if you are doing it, should be only adult patients. But nowadays, most of the people will do the endoscopic technique that is called functional endoscopic sinus surgery. Now we have spent 1 hour, so we'll take a short break of about 5 minutes and then start again. Right, now we are getting back to the talk again. Angiofibroma of the nasopharynx is the slide displayed, which is another kind of nasal polyp or a nasal mass that can occur. Now, this is a benign tumor which is very vascular, and it is commonly seen in adults and males. So the females can be very happy. And it starts in the lateral wall or roof of the nasopharynx. And the etiology of this condition is considered to be uncontrolled proliferation of erectile tissue in the nasopharynx. So you wonder how the erectile tissue can get into the nasopharynx, but for erectile tissue, everybody knows where is that material is that in the male. But this is like the turbinate tissue is also considered to a certain extent like erectile tissue because they have vascular spaces that can sometimes get filled with blood and then you can get the thing enlarging. And then certain times the turbinates can get smaller by releasing the vascular channels or emptying the vascular channels. So a certain kind of erectile tissue or similar tissue to erectile tissue is there in the nasopharynx. And people think that this uncontrolled proliferation of the erectile tissue in the nasopharynx, and they think it has something to do with the hormonal changes which occur in the adolescent male. So this disease is considered exclusively in males, and they usually get a mass or a vascular mass in the nasopharynx, and that can give rise to a lot of trouble. So what can happen is the mass will enlarge and it can cause progressive nasal obstruction. And because it's a vascular mass, it tends to cause epistaxis. So they get recurrent epistaxis and severe epistaxis. The speech can get altered due to nasal obstruction. The nasopharynx, the eustachian tube is also there. So the mass in the nasopharynx can block the eustachian tube and that can give rise to middle ear collecting fluid. That will lead to conductive deafness. So middle ear effusion and conductive deafness can occur. Then of course there is a lump they will complain of, and sometimes a lump can be seen in the nose or throat. And if the tumor invades the surrounding areas, you can get proptosis, broad nasal ridge, asymmetry of cheeks, and also sometimes this lesion or this tumor can extend into the brain. So it's not a very good thing to have. So how to diagnose? Usually adolescent males come. History of epistaxis. Tumor is also very vascular. It is not very enjoyable surgery for the surgeon. So for the surgeon, it's a bit of a challenging surgery to try and resect the nasopharyngeal angiofibroma completely. And then there are various approaches described. So transpalatal is you open the mouth and make an opening through the hard palate into the nasopharynx, and then resect the tumor and repair the hard palate. Then the lateral rhinotomy is you open the side of the nose and get into the nasal cavity, and then through the nasal cavity you go into the nasopharynx and remove the tumor. And there's another approach called midfacial degloving, which is not commonly practiced, but that is also another approach. Endoscopic approaches are again very popular now. So whatever approach you use, we must try to remove the tumor completely, because if you leave the tumor behind, then it can grow again. Also, irradiation is considered as part of treatment, one modality of treatment for this condition, but not as the primary treatment. Irradiation is used for residual or inaccessible tumors or recurrences. Preoperative embolization is a useful thing because of the vascularity. If you can embolize the feeding vessels, then you can do the surgery with less bleeding. So we usually get our interventional radiologist to do a angiogram or digital subtraction angiogram or a DSA, and then at the same time, when they identify the feeders, they can pass a small catheter and into the feeding vessels and use some material to block the feeders to the tumor. And if you can do that, that is called embolization. And that is going to be a very useful technique for us to do surgery, because the surgery becomes less bleeding and less troublesome. Now, external carotid artery ligation also might be considered if the bleeding is very excessive and if you find it difficult to resect. Now, this is a boy who came to us with angiofibroma, very extensive angiofibroma. You can see he has got proptosis, he has got cheek swelling, and if you see the CT scan, this is how the angiofibroma has invaded the orbit, and not only orbit, it has invaded the brain also. This is how it has gone into the brain. So extensive angiofibroma. In this patient, we thought it was too much for us to do operation for him. So we referred him to our oncology colleagues to get some radiation treatment. But because he's a small child, the oncologist didn't want to give any radiation because of the risk of later developing malignancies. So because we were left without any other option, we have to do a surgery, and we did this surgery with the neurosurgeon because it's partly inside the brain. We managed to take the whole tumor out, but the patient didn't survive because it was very extensive bleeding and a lot of blood had to be transfused during surgery, and the patient went into disseminated intravascular coagulation, which is a complication of major transfusions, and patient died in the post-operative period. So you can see how extensive the angiofibroma can be and how bad the results of treatment will be. Although benign condition, this can happen. Then we have inverted papilloma, which is an intermediate grade tumor. It is found that this tumor can undergo malignant change with time. And also some people think the same tumor can have different pictures, benign picture and the malignant picture in different areas of the tumor. So therefore it's considered an intermediate grade tumor. So it's not totally benign, it's not frankly malignant, but there's a malignant potential. It's commonly seen in men over 50 years, and there is a tendency to recur. So if you even leave a small bit of tumor, it will start growing into large mass after some time. The clinical features are nasal obstruction, pain, epistaxis, and you can see a pale fleshy polyp in the nose. Now this can be biopsied, so biopsy will confirm the diagnosis, and management is total excision of the lesion by whatever technique. You can do an endoscopic technique, you can do an open technique. Whatever technique we have to use, take all the tumor out and the base also to be completely cleared so that we don't leave a trace of the tumor. And after doing that, we may have to monitor the patient after some time or on regular intervals with imaging, because if you have left even a bit of tumor, it's going to grow and make another tumor. So therefore, we do the surgery completely and then get the histology confirmed as a benign condition. And then after some time or after interval, we may do another scan and find out whether it is growing again. So some of the patients we do interval assessments after resection of inverted papilloma. Then we come to the malignant tumors of the nose and sinuses. Now the commonest malignancy is squamous cell carcinoma. Then other ones are adenoid cystic carcinoma, adenocarcinoma. Adenocarcinoma is common in woodworkers, and hard wood dust is considered as an etiological factor for adenocarcinoma in the nose. Then melanoma and lymphoma are the types of malignant tumors. Now, squamous carcinoma or tumors of the nasal cavity, they are generally diagnosed late because initial symptoms are not very specific. So you might have some kind of catarrhal illness or non-resolving common cold type of feeling. Therefore, it is not very specific. So a patient might think that he has got sinusitis that is not clearing up. But gradually, the disease will spread and develop more and more symptoms. So what are the things that can happen with the spread? Now, if the disease spreads superiorly, it can involve the brain. So sometimes the disease goes into the brain by erosion of skull base. Sometimes it might inferiorly erode, and if it erodes the palate, it can appear like a mass inside the mouth. Laterally, it might spread into the orbit and can lead to proptosis or vision loss. Medially, it can extend into the nasal cavity, causing epistaxis and obstruction. Posteriorly, it can go into the sphenoid and pterygopalatine fossa. Again, these areas are very deep-seated areas, and sometimes the patient may not show any specific symptoms due to involvement of these areas. Regional lymph nodes also can get involved with the disease. So how to make a diagnosis? One of the ways to do is high index of suspicion. So high index of suspicion is you are generally not believing that this is a benign condition. So if a patient comes to you with a catarrhal symptoms, if the patient is an elderly patient, then you might think, well, although this is just like catarrhal symptoms, this could be a malignancy. So that is because you have that in your back of your mind all the time. Sometimes I have high index of suspicion about medical students. I think they are not interested in learning ENT. They want to cut the classes and play the fool. So I give them a very strict administration. So they have to come and work every day. Otherwise, I will try to catch them and punish. So that is again high index of suspicion. So if you get an elderly patient with facial pain, blood-stained discharge, now paresthesia of the cheek can occur when the maxillary sinus tumor involves the intraorbital nerve. So if you have paresthesia of the cheek, that might be a feature of malignancy in the maxillary sinus. Spontaneous loosening of teeth also is another sign. When the tumor erodes the maxillary sinus flow, the upper dental, upper teeth are inserted into the maxillary bone. So you can get loosening of good teeth when there is a tumor in the maxillary sinus. Anterior rhinoscopy, fiber optic endoscopy, rigid endoscopy, CT scan. All these will help us in the diagnosis. EUA and biopsy or RNE and biopsy. EUA is examination under anesthesia. But if you can see the tumor coming into the nasal cavity, you can do RNE or rigid nasal endoscopy and biopsy, and that will give you the histological diagnosis. The treatment is complete surgical removal if possible. So you can do lateral rhinotomy and remove it, or you can do the excision, wide excision of the lesion. You can do total or partial maxillectomy. And if the tumor has invaded the brain, then we might do a combined surgery with the neurosurgeon called craniofacial resection. And after that, we refer the patient for radiotherapy. When you remove a lot of facial tissues, the patient can get a facial deformity. So rehabilitation with various prostheses and implants might be necessary after treatment. Then the other malignant tumors, adenocarcinoma, as we said, hardwood dust is important as etiology. Adenoid cystic carcinoma has a specific feature of spreading along the nerve sheets. So that is again, we have to do a wide excision. Olfactory neuroblastoma is a relatively rare condition from neuroectodermal tissue. It arises, and there are secretions of vasoactive amines may be secreted by these tumors, and the treatment is usually total resection and radiation post-op. Malignant melanoma can occur in the nose, which is rare. Surgical resection, wide surgical resection is treatment. Sarcomas are rare. There can be fibrosarcoma, osteosarcoma, or lymphosarcoma. Now, lymphomas can occur in the nose. There are two types. One is called Stewart's lethal midline granuloma. In this situation, you get destructive lesion in the middle face, including the nose and the upper lip area. You can get a destructive lesion and treated by radiotherapy. And there's a malignant lymphoma of Burkitt's type, which has a strong association with Epstein-Barr virus, which gives rise to a marked swelling of the face, and that is treated by chemotherapy. You can get metastatic lesions in the nose and sinuses, which are rare. It can be from breast, prostate, and thyroid. Now, this is a picture of midline granuloma, which is a T-cell lymphoma. Then we come to the miscellaneous conditions. And epistaxis is one of the emergencies we can get in ENT. So epistaxis can cause very significant bleeding sometimes, and patient can collapse, or it can be sometimes minor bleeds which are not very much bothering to the patient. So epistaxis can occur in different degrees. If you think of your etiological factors, you can see that systemic conditions also can give rise or precipitate epistaxis. Hypertension, hereditary hemorrhagic telangiectasia is a hereditary condition where the capillary tufts are abnormally formed. So because of that, they have bleeding from all over the place, but nasal bleeding is fairly common. Chronic liver disease can have clotting factors deficient and cause bleeding or bleeding tendency. Blood dysplasias, DYS, it should be not DUS, blood dysplasias. And certain drugs also can have increased bleeding tendency. So commonly we use aspirin, clopidogrel, warfarin. These drugs can cause excessive bleeding tendency and sometimes epistaxis. Local conditions can be some local lesions like hemangiomas, traumatic conditions, sinusitis, hay fever. Rhinosporidiosis is a condition that is due to some organism causing a polypoid lesion. Angiofibroma and carcinoma we have discussed about. Foreign bodies can cause bleeding. Pyogenic granuloma. So when you think about the percentage of conditions or causes, you find large number of patients, we can't find the real cause. So we call them idiopathic. Now, clinical features, any age can be affected by epistaxis. Males are slightly commonly affected than females. The site of bleeding, if you try to examine and find, sometimes there's a small vein behind the columella. There is columella is this middle part of the nose. Retrocolumella vein. Lickle's area is a rich vascular anastomosis by arterial, various arterial branches that supply the nasal septum. So you get ethmoidal artery, sphenopalatine artery, branch of the facial artery. Like that, there are several arterial branches form a Lickle's area. Then the postnasal space also can sometimes have bleeding due to atherosclerosis of vessels. There's a nasal lesion that can be a source of bleeding. So if the patients present to you, how can they present? They can present with recurrent minor bleeds as outpatient, or they can have massive bleedings, several pints of blood. They have bled and serious bleeding, active bleeding, or patient may be collapsed at the time of your examination. So what are the things you can do? Measures control nasal bleeding. Now, ice has been traditionally applied on the nose to stop bleeding. So, if you want to apply ice, there's no harm. You can use a polythene bag with a little ice, few ice cubes, and keep it over the nostril and over the nose, and see whether it stops bleeding. The patient being seated up also sometimes might help to reduce bleeding. Those are the things you can try at home, but of course you can use the finger pressure as a method of stopping bleeding. Finger pressure is only for the lower part of the nose. You can hold your nostril like that with the two fingers without applying a lot of pressure, just a gentle pressure. Now, retrocolumella vein and the Lickle's area, the bleeding might be arrested by finger pressure. So if you do like that, you might block the blood vessel, but you don't have to be very hard, very harsh. Gentle pressure might stop the bleeding. The bleeding is anterior, but postnasal space bleeding you cannot stop by finger pressure. So their bleeding might continue and blood will come into the throat. Now, cauterization with silver nitrate or electrocautery can be applied for small bleeders on the septum or the retrocolumella vein. So it is done as outpatient procedure. We can spray the nasal cavity with some local anesthetic and then precisely apply silver nitrate stick or electrocautery on the bleeding point to cauterize the bleeder. When the patient is admitted with active bleeding, we can't use the cautery technique for that. Then we have to use anterior nasal packing. So we will use a nasal pack to compress the nasal cavity on both sides. We have to use nasal packing. A long piece of ribbon gauze impregnated with Vaseline or some ointment we have to apply into the nose. Anterior nasal packing stops bleeding, then we can keep the packs for 48 hours. And the 48 hours period, we can assess the patient's general standards and general disability and the diseases. So if they have any hypertension, we have to control the blood pressure. There are any deficient clotting factors or liver function abnormalities, we may have to correct those. So after 48 hours, we can remove the packs and seal. But if the patient does not stop bleeding with the anterior nasal pack, then there is a thing called post nasal pack, or we can use a Foley catheter to stop bleeding from the nasopharynx. So Foley catheter balloon can be used, and then you can pack the anterior nostril also with a anterior nasal pack. So this mechanical pressure by anterior packs, posterior nasal pack, in the Foley catheter, if they stop bleeding and if the patient doesn't have any other contributory factor, then we might be able to remove these packs after 48 hours and the patient should be free of bleeding. But if the patient keeps bleeding every time we take the packs out, there's significant bleeding. Then of course we have to do a rigid nasal endoscopy to find out whether there is any lesion that we have missed. If there is a lesion, of course we have to attend to that lesion and see whether we can remove the lesion or make a diagnosis of that condition and treat. But if there is no lesion and the patient keeps bleeding every time we remove the packs, then we have to go and clip one of the supplying vessels to the nasopharynx or nasal cavity, and that is the sphenopalatine artery. So, if you know the anatomy of the nasal cavity, the sphenopalatine artery comes through the foramen called sphenopalatine foramen, and the sphenopalatine foramen is situated posterior to the middle turbinate. So, if you can identify that endoscopically by doing a small dissection, we can usually identify the sphenopalatine foramen. So, sphenopalatine foramen is the one that will exit the sphenopalatine artery into the nasal cavity. So, you can identify that area and you can apply clips to block the vessels. Then you can ligate the vessels supplying the nose. Now, ligation of vessels is now commonly not practiced because endoscopic techniques are available. But earlier, when we didn't have endoscopes, we used to ligate external carotid artery in the neck. Under local anesthesia, we can make an incision here and explore the arterial carotid arteries and find the external carotid artery and ligate. Similarly, anterior and posterior ethmoidal arteries, you can make incision near the medial canthus here and then separate the orbital periosteum, and anterior ethmoidal and the posterior ethmoidal arteries can be identified and cauterized. Then, of course, there is a thing called tranexamic acid, which is an antifibrinolytic agent that is also useful to treat epistaxis patients. So, tranexamic acid can be used if there is no contraindication. You can use tranexamic acid to reduce nasal bleeding. Important thing about epistaxis is complete assessment of the patient is necessary, not to attend to only to the nasal cavity, because systemic factors should be identified and treated at the same time. Now, offensive smell from the nose is a condition that is distressing for the patient, and one of the conditions which can get offensive smell from the nose is a foreign body. Now, this is very commonly seen in children. So, children will have they will insert the foreign body into the nose and they will forget. So, when they are brought to us with offensive smell, what we need to do is use a good light and examine the nasal cavity. Usually, the foreign body can be seen. If you can see the foreign body, we can remove the foreign body in the clinic itself. So we tell the parents to hold the child in a particular way, sit in front of the doctor, and then doctor will flash the light and use a small instrument and quickly take the foreign body out. So foreign body in the nose can be removed in the clinic, commonly seen in children. If the child is not cooperative, or if the foreign body goes into pieces and you can't remove it completely, then you might consider examination under anesthesia. But if there is no foreign body seen and if the child has no symptoms, then of course there is no indication for examination under anesthesia. So you have to have an indication if you want to do a UA. Then the second condition that can give rise to bad smell is a rhinolith, which is formed inside the nose. So it's a stone forming inside the nose. Uh, it's a very irregular, large foreign body usually when we see. So over a period of time, the rhinolith will grow because I think the secretions of the nasal cavity will harden and dry up around the focus, and that will form the rhinolith. So if you see this rhinolith, it's a irregular large foreign body. Therefore, usually they are removed under